retinal breaks, and second is clots and hemorrhages. So I'll just show a couple of videos to just say that share that how to manage if you encounter, although you should try your best to avoid a iatrogenic break in PDR surgeries, but sometimes you do get it. So this video will show you why do you get it, and then how can you address it. This was again a PDR subhyaloid hemorrhage, you can see, and you might wonder why we were doing surgery for this, but you can see this traction distorting fovea, and after anti-VEGF you can again see it is getting worse. So this was again these are rather tougher cases when maximum retina is attached and you have a very limited tractional detachment. So as you will see here, yeah. So this is typically that answer to that question. Now my right hand is holding the cutter. We are doing bimanual surgery, and left eye is holding this membrane, and I am slowly dissecting it from retina. And now at this point, when I realize that I'm not getting the right angle, I will switch my hands, and now you will see I have cutter in my left hand and forceps in right hand. And now you see what I am doing. Even when I am bimanual, I am not bimanual. It's something like people used to do with mask and seat belt. You have protection, but you are not using it. And you see what happens here after this. I just went with the flow and there was a tear. If I would have used forceps at this step, I would have easily avoided a iatrogenic tear. So, and you see a gush of blood coming, and when you see excessive bleeding, I think you suspect that you have created a tear. And this was definitely very thickly adherent membrane. And now, how do you address it is, one is you clear the traction around this, but another thing which I learned, I think last few years, is that diathermize the edges of this iatrogenic tear if you get it in PDR, because last thing you want in PDR is subretinal bleed. We were all dreaded and worried about vitreous cavity bleeds, but subretinal bleeding is even worse in PDR cases. So immediately you diathermize it, just like you do for your reg RD cases where you do it for marking. But here it helps you, most of the times this break will happen at the base of neovascular complex. So it will actually cauterize that NVC also. And of course, you carry on with your dissection, bimanual dissection now, and separate these sheets. And now you have to be even more meticulous in separating all these sheets around this break. So the most important thing is diathermize and clear the traction. And of course, I think ILM peeling we have already discussed. I'll just skip that part. And then you do laser, and I think choosing tamponade just doesn't depend on creating a break and tractional issues. It's also about visual rehabilitation and need of that patient. If it's like one-eyed patient, or that patient is less likely to follow up, we always choose silicone oil over gas. Rather, we use gas very less in our setup. Either we use air. Most of the cases where you feel like using gas, actually they don't need gas even. They need only air tamponade. But yes, if you want to give early rehabilitation, then silicone oil definitely is an advantage. And you see patient, the final outcome was not compromised because of that iatrogenic break. And again, this was again a patient where you will see, this was more of a advanced PDR, one eye already lost, and this was a combined detachment. And again, the principle is same. You have to create multiple islands here also. It's just a detached retina with PDR, so you will have those islands, so separate them from each other. And again, something which we were discussing, put a PFO bubble at macula so that you will see a lot of blood is accumulating around the bubble, but your foveal macular area is still spared. And here you see sometimes, because in detached retina, I think is more likely to tear up. And you see a gush of blood, and this tear has been now created. Again, the principle is same. You dissect it from all around. And you see, I think if you manage it well, do good laser, and this amount of heme, I think it clears up. I think this is hardly at 1 week follow-up. So this is again something I want to share with fellows, that if you have a thin layer of blood at macula or posterior pole, need not worry, you put silicone oil, tamponade, most of the times it clears up. So need not be that scared about that also. Now, what to do about clots? I think if you encounter big clots intraoperatively, or some of them if they were present from pre-operative period also, how do you manage it? So I think simplest is, which most of my VR colleagues are very well aware. If you have, you can just use this reflux action from your back flush, and this is a very easy and faster way of getting rid of blood. Just be careful, don't direct your stream towards fovea and neovascular complexes. Avoid directing it to them. Otherwise, I think it works very fast and you can get rid of blood very easily. Now, again, I think unfortunately these photographs have not come up. This was again a very aggressive PDR patient, and after completing all your dissection, which you have seen in all the videos in this instruction course, when you get finally you get a blood like this. Again, how to address it is, one is, now because you have done the dissections, you know where your NVCs are lying. Don't try to pull that clot over that areas. And again, your disc is the favorite site where you can again pick up the clot. And I'm sorry, yeah. And you can actually, you will see this, you can actually release this clot from the over the disc, and that is the safest area, because you know you have done dissections, chances of creating a break there is very less. And get rid of that big clot, and then rest of the liquefied blood you can clear with reflux action, and in the end you will have a very small size of clot in multiple areas which will easily get absorbed. But sometimes you have a very thick clot like disc. We have actually reported this also. It can actually look like a nucleus, and none of your 25 gauge or even 23 gauge cutter is going to remove it easily. So I think you can use a phacophraगmatome also. I think this is just to share this idea which I think Dr. Reddy gave us maybe 6-7 years back. We were struggling with a big clot in RP Center's OT, and then he reflexively said, why not use a phragmatome? And then I think we have shown in that publication that it was hardly over in 30-40 seconds. And it was a huge nucleus-like clot. So this is one small tip for all the... I'll just quickly share one last video and I'm done. Again, we encountered a massive clot recently. You see this. This was organized blood with detachment and massive subretinal clot. It was looking like a choroidal mass. We got the histopathology also done, but again, something which I wanted to share was, because I wanted the tissue for sample, I had to use a foreign body forceps bimanually to take out this huge clot. So, and we actually treated it like a mass lesion until we got the histopathology report, which has shown that it was just blood from PDR. So I think with this, I'll end my presentation and we can take questions. Thank you.
One point, it's best to relieve the traction over that break and drain as much as SRF as possible. So this allows the retina to settle down, and the counter traction is also available once you start peeling at other areas, just to add to your videos.
Yeah, great point, I think.